Doctor, I think that was really exhilarating and very, very interesting to have gone through. Two things that I learned from the session, considering I'm a non-medical. One, that we are the strongest sex because we can procreate, but kissing is still a problem. I'll keep that in mind. All right, thank you very much once again. And the only thing that was missing from the Indian accent was the Indian nod. We'll convene outside for that. Time for our next session. I know, ladies and gentlemen, you're getting a little antsy. We will take a break for lunch in about an hour, but thank you so much for keeping a full house, and thank you so much for being here as well. It gives me great pleasure to announce our next speaker, Dr. Kirpalani, Dr. Dilip Kirpalani, consultant nephrologist and kidney transplant physician and assistant professor of nephrology at Bombay Hospital Institute of Medical Services, Mumbai. Specialist in clinical hypertension, certified by American Society of Hypertension, ASH, gold medalist at MD Medicine in 2006 batch at Kasturba Medical College, Manipal, fellowship in nephrology and hypertension at Ottawa Hospital, Ottawa, Canada, in charge of hypertension clinic at Bombay Hospital. He has multiple publications in national and international journals. May I please invite him on stage. With a round of applause, Dr. Dilip Kirpalani. And to felicitate him, I also invite on stage Dr. Govind Jainani. Can I please have you on stage to give away a small token of felicitation to him? Thank you, Doctor.
Take this later. Yeah, I'll just keep it on this. Yeah, thanks. Changing the slide. I just need to know how to use this. Which, can I go back? Good afternoon, ladies and gentlemen, my elders, dear friends and colleagues. Thank you for the very kind introduction. At the outset, I'd like to thank the APPI and TransAsia for giving me this wonderful opportunity to speak here today. I must let you know at the outset that this is probably the first time I'm addressing an audience purely of pathologists. I hope I do justice to this topic in the next 25 to 30 minutes. I'll be talking on the importance of accurate urine analysis in the diagnosis of kidney disease. Now, urine analysis, as we know, is an age-old art, and yet it's probably the most neglected at times. Somehow, it seems people tend to, we as clinicians particularly, tend to not give it as much importance as it has. And I hope my endeavor in the next 25 minutes is to let you know what the importance of urine analysis will be in the diagnosis of various kidney diseases. So the first question, a very basic question, why is urine yellow? And jovially, I may say it because it contains gold, but what I mean by that is that it contains a gold or a wealth of information. And I'll allude to that in the next few minutes. Urochrome is the pigment which makes the urine yellow, but nobody really has understood up till now what urochrome's chemical composition is. Now we know in the earlier days we had this big instrument called the urinometer for specific gravity measurement. We don't really use it nowadays. It's got its problems because you need a large volume of urine to be able to look at the specific gravity with this instrument. So today we have these new urine dipsticks which could tell us all these parameters: leukocyte, nitrite, urobilinogen, protein, blood, ketones, bilirubin, glucose, and within a few minutes, with the help of the urine dipstick and the automated urine analyzer, we could get a wealth of information on the various composition of that urine. Now, individually, if we analyze, some of the basic things which we always tend to forget in the analysis of urine is we always tend to neglect the pH and the specific gravity. So I'll speak about the specific gravity first. Specific gravity has a lot of importance, particularly in the analysis of proteinuria. We must remember that merely saying that the urine protein is 2+ or 3+ or trace is not enough. When we interpret urine protein excretion from the dipstick, we have to do it ideally in the, we have to consider the specific gravity. So when we look at the ordinary urine routine and we see 3+, it doesn't tell us much unless we look at the specific gravity as well. Proteinuria has to be interpreted in the context of specific gravity. So for example, if your urine is 3+ protein, but your specific gravity is as high as 1040, most likely this proteinuria is insignificant, because 3+ in the face of a highly concentrated urine is insignificant. On the other hand, a 3+ or even a 2+ in the presence of a specific gravity of 1010, a dilute urine, will be a very significant proteinuria. In a dilute urine of specific gravity 1004, even a urine protein trace could be highly significant. And this term, isostenuria, is used for the specific gravity in a typical CKD patient when the patient has lost his ability to both concentrate as well as dilute the urine. So the term isostenuria is used for 1010 specific gravity, which is what we call 1010 or low and fixed specific gravity. And that's typical of a CKD patient once the CKD has advanced beyond stage 3. So specific gravity has its importance, we must not neglect it. Urine pH, another neglected urine parameter, but also gives us a lot of information, particularly in the analysis of a patient with renal tubular acidosis and what type of renal tubular acidosis the patient has, whether it's distal or proximal, that is type 1 or type 2. Urine pH is very important. The important thing to remember in urine pH is we have to do it on a fresh urine, because if you look at the pH of stored urine, it will be 10 to 20 years. If nobody intervenes on him with aggressive sugar and blood pressure control and renin-angiotensin blocking agents being introduced, this patient will progress to end-stage renal disease or dialysis in about 15 to 20 years. As you can see from this slide, about 15 to 20% of diabetics at onset have microalbuminuria. That means 15 to 20% of diabetics at their diagnosis of diabetes already have chronic kidney disease, which is a staggering and an alarming figure. On the other hand, if you intervene in time with aggressive blood pressure and sugar control and introduction of renin-angiotensin blockers and dietary protein restriction, we can substantially delay the onset to dialysis, particularly if we can pick up the patient in this early stage. The idea is pick him up when he's in microalbuminuria stage and prevent him from going on to overt proteinuria and renal failure. So with that, coming to, just before I get on to proteinuria, this is something which we must remember when we are interpreting microalbuminuria. If anyone has a urine infection, a fever of any cause, uncontrolled blood pressure or uncontrolled sugar, has had a recent convulsion, has heart failure, has ketoacidosis or is pregnant, do not interpret the microalbuminuria immediately. These are the causes of false or spurious microalbuminuria. If a person has any of these, then you'll have to wait for this to subside and then retest for microalbuminuria and then see whether the patient really has microalbuminuria. So keep this in mind. Now coming to proteinuria. Proteinuria can be glomerular or tubular. Glomerular proteinuria is due to failure of the physiological barrier to glomerular filtration of protein. Tubular proteinuria is usually due to the failure of the tubules to reabsorb the protein, and typically glomerular proteinuria is here what we are interested in. glomerular proteinuria is much more significant and larger in quantity. Just like there are spurious causes of microalbuminuria, there are false positive reactions in our tests for proteinuria. In the reagent strip test, if somebody has alkaline urine, then that could test false positive for proteinuria. And if anyone has received any of these agents, then the acid precipitation test could test falsely positive for proteinuria. Why are we harping on proteinuria all the time? Because proteinuria itself is nephrotoxic. Whether you look at a diabetic patient or a non-diabetic patient with proteinuria, whatever the cause of the proteinuria, if the proteinuria is significant and you don't do anything for it, and you let it go on leaking into the tubules, ultimately, this proteinuria causes increased glomerular pressure, there is increased filtration of proteins, and ultimately these proteins which get reabsorbed in the renal tubules lead to interstitial nephritis and interstitial fibrosis, and that causes the GFR to drop. So proteinuria is nephrotoxic by damaging the glomeruli, and proteinuria is nephrotoxic by damaging the renal tubulointerstitium. Therefore, it is mandatory to control proteinuria at the early stage when the GFR is normal or near normal. This was just a trial of ACE inhibitors in progressive renal insufficiency, which showed that a proteinuria reduction of 1 gram reduced your risk of renal insufficiency progression by 31%. And if you were able to reduce your urine protein leakage by 3 grams or more, you would reduce your chance of your CKD progression by about 66%. So these are very encouraging figures. How much protein is passed daily? We know that the 24-hour urine protein excretion or a timed collection should be measured, and this should ideally be always accompanied by a 24-hour urine creatinine estimation so as to confirm the adequacy of the urine collection. If the 24-hour urine creatinine is low, then it tells you that probably the volume sample is inadequate. Normally, we know that 150 milligrams of protein, up to 150 milligrams per 24 hours, is the normal urinary protein excretion. Remember, now I'm talking protein. I've talked about albumin. Now we are not talking albuminuria. We are talking proteinuria. The definition for nephrotic syndrome is anyone with a protein excretion more than 3.5 grams per 24 hours per 1.73 square meter body surface area in an adult. And in a child, the definition is as follows: more than 40 milligrams per hour per square meter body surface area. Now we know that 24-hour protein collections could actually be quite cumbersome, and even in children particularly could be difficult at times. So we have an alternative called the UPCR, which we do on a spot urine sample, which is the urine protein to creat ratio. And the normal is less than 0.15. And the good thing about this is it almost always correlates quite accurately with the 24-hour protein collection. So if you have somebody with a UPCR of about 2.0, then you could say roughly the patient is passing 2 grams of proteinuria, even if you cannot, for any reason, collect the 24-hour protein. This slide I've already alluded to earlier, that proteinuria should be interpreted in the context of specific gravity, and proteinuria should be interpreted in the context of the serum protein. Now, the normal serum albumin, as we know, is 3.5 to 5 grams per deciliter. Now, I'll explain this in the next couple of slides. So this is an example of a person with nephrotic range proteinuria, 6 grams. He has a serum albumin of 2.2. So such a person is frankly nephrotic. After you treat him with whatever immunosuppressives, if the 24-hour urine protein falls from 6 grams to about 1.2 grams, but the serum albumin falls from 2 to 1 gram per deciliter, such a person is actually worse, because his proteinuria has fallen only because his serum protein stores have gone down. Therefore, always interpret proteinuria in the context of the serum protein and the serum albumin. Conversely, if the person who is being treated with 6 grams proteinuria, after treatment, if his proteinuria has come down to about 2.5 grams, but his serum albumin has risen from 2.2 to 3 grams %, then such a person is actually improving. So it's the serum albumin which tells us the adequacy of our treatment for proteinuria. Proteinuria, as we know, goes by the company it keeps. So in this one slide, it tells us the importance of how important a urine analysis is. Without a kidney biopsy, just merely by looking at the urine sediment, we can roughly diagnose what type of kidney disease we are dealing with. If the urine sediment shows proteins, RBCs and red cell casts, this is a glomerular disease. It's an acute glomerular nephritis. If the urine protein is accompanied by white cells, WBCs, and the urine culture is negative, most likely you're dealing with an interstitial nephritis. Interstitial nephritis is one of the causes of sterile pyuria. If you have urine protein with fat globules, this goes in favor of a nephrotic syndrome. And if you have what we call an absolutely bland urine sediment, that is a urine protein with no cellular elements, then this would be in somebody with long-standing hypertension. Such a person's CKD is probably due to hypertensive nephrosclerosis. So I've talked on proteinuria, just a few slides on red urine and hematuria. Red-brown urine is not always due to hematuria. It may be due to hemoglobin, myoglobin, and a whole lot of drugs and other dyes. The common causes of hematuria are glomerular disease, sometimes interstitial diseases, vascular problems like AV malformations and over-anticoagulation, and of course urological causes such as stones, malignancies. And sometimes we have miscellaneous causes of hematuria such as sickle cell disease and hypercalciuria. So this is an extensive list of the causes of hematuria. Now, this is the age-old 3-glass test which you all are aware of. Merely by looking at the urine sample in 3 glasses, we can tell roughly, approximately, whether the hematuria is coming from the kidneys, urethra, or bladder. So if you have terminal hematuria only in the last glass, that's bladder. If you have a persistent hematuria through all the glasses, that's a renal source of hematuria. And if you have initial hematuria but no blood in the subsequent samples, then that's likely to be a urethral cause. This slide gives me a basic differentiation of how you differentiate between a renal and a urological cause of hematuria. I'd just like to say that dysmorphic RBCs go in favor of, or what we call sometimes crenated RBCs go in favor of a glomerular disease. So if you have dysmorphic RBCs or if you have red blood cell casts, then such a person's hematuria is because of a glomerular disease, and such a person will need probably a kidney biopsy. On the other hand, if both dysmorphic RBCs as well as red cell casts are absent, then you need to investigate the lower urinary tract for the cause of hematuria. Once again, glomerular hematuria will show up on casts. It will show casts, and you need phase contrast microscopy to diagnose crenated RBCs. Now, unfortunately, in Mumbai, we don't have that many labs looking at this particular aspect. So I once again urge pathologists to do phase contrast microscopy. And when you look for casts, it's important to look in the fresh urine and look at the edge of the cover slip. So I don't need to obviously tell you this, but what I'm trying to emphasize is that as pathologists, if you all could have more phase contrast microscopy, and if we could get more information on casts, RBC casts and dysmorphic RBCs, it could help us in our evaluation of hematuria patients in a major way. Because once we know whether the cause is glomerular or non-glomerular, then it becomes very easy for us to proceed along the correct lines. Non-glomerular hematuria, this is actually a repeat slide, but it just looks at the common causes of non-glomerular or urological causes are stones, tumors, and trauma to the lower genitourinary tract. Lastly, urine analysis in urinary tract infections. Now, if somebody has a UTI, then there will be pyuria, and the leukocyte esterase and the nitrite test will be positive. But this is not enough to diagnose UTI because you need a urine culture. We know from our traditional teaching that normal pyuria or normal number of pus cells in urine is 0 to 1 or 0 to 3 in a male per high power field and 0 to 5 in a female. The commonest cause of pyuria is a bacterial UTI, but here I've shown you a list of causes of sterile pyuria. So if you have persistent pyuria and a sterile urine culture, then think of one of these causes: acute or chronic interstitial nephritis, vesicoureteric reflux, genitourinary TB, and sometimes just simple local causes such as vaginitis. Now, to summarize, this would be the typical routine urine examination, which would look at all these parameters in the general examination, that is the color, transparency, reaction, specific gravity, and then the chemical examination. This would be followed by the microscopic examination. And now here on this slide, I'd just like to mention two things. One is, of course, that a lot of our labs now have changed over from telling us as per high power field. Rather than that, they are now using these flow cytometers to look at the quantification of RBCs and WBCs per microliter. And this obviously with these newer techniques gives us more information. That's one. And the other thing I'd like to mention on this slide is that merely the presence of bacteria in the microscopic examination of urine is not enough to diagnose UTI. You need the culture to make the diagnosis of bacterial UTI along with a good sensitivity report. This is just an example of a patient with an E. coli ESBL with a significant colony count of more than 1 lakh. And here is a typical modern sensitivity report. And what I'd like to emphasize on this slide is that we should not be anymore using the +1 and the +2 and the +3 and the +4 for the sensitivity reporting. And there should be no sensitive and highly sensitive and intermediate and resistant. It should just be as per the MIC values, as you all know. And based on the MIC values, we should just say whether the drug will work or it will not work on the bug. That is, it's sensitive or resistant. This is important. Lastly, I'd like to mention that I've talked on hematuria, I've talked on proteinuria, and I've talked on pyuria. In the analysis of acute renal failure, or AKI as we call it, the urinary sediment gives us a wealth of information, which I'll just allude to in the next couple of slides. So just based on the urinary sediment and what the composition of it is, we can get a brief idea of what type of AKI we're dealing with. So if you have a normal urinary sediment, or again what we call a bland urinary sediment, some of the causes of the AKI would be pre-renal AKI or an arterial thrombosis or a post-renal AKI. That means an obstructive uropathy leading to acute renal failure. If you have granular casts, it could go in favor of acute tubular necrosis, which is usually due to sepsis or ischemia. It could be due to glomerulonephritis as well. If you have epithelial casts, that again could be seen in acute tubular necrosis, acute interstitial nephritis, and acute cellular rejection in a transplant patient. If you have RBC casts, that goes in favor of an acute glomerulonephritis or a vasculitis, and sometimes even in malignant hypertension with acute renal failure, you get RBC casts. White blood cell casts go in favor of an acute interstitial nephritis or a severe bacterial pyelonephritis. And on this slide, I'd just like to mention the eosinophils. Now, urine for eosinophils is something we don't test for routinely because we need the special stains for this. But again, by testing for urine eosinophils, we could get a wealth of information in our AKI patients, because urine eosinophils are often positive in antibiotic-induced allergic interstitial nephritis, and it's also seen, urine eosinophil positivity is seen in arthroembolic disease, which you get, which is a type of acute renal failure you can get following a contrast injection or angioplasty. And this is actually my last slide. We have now various urinary indices which help us to differentiate pre-renal AKI from intrinsic AKI, that is acute tubular necrosis. Here again, the only one I'd like to emphasize on is the urine osmolality. And once again, I urge laboratories to test for urine osmolality very regularly, because based on urine osmolality, we can base our diagnosis of what type of acute renal failure we are dealing with. In pre-renal causes of AKI, the urine osmolality is typically raised, whereas in intrinsic kidney damage like acute tubular necrosis, the urine osmolality drops. Even the urine sodium is a very important test, because if the patient has not received a diuretic, the urine sodium will be low in a pre-renal AKI and high above 40 in an intrinsic AKI. So, dear friends, once again, I'll just conclude by saying the urine examination is a gold standard in the diagnosis of kidney disease because it contains a wealth of information. Thank you.
Thank you very much, Dr. Kirpalani. Ladies and gentlemen, our last session before lunch, we shall have another half in our session. And to do this session, may I please invite on stage Dr. Ajit Menon, MBBS, MD, DM, FS, CAI, ranked first in the college at the MD examinations held in Jan 1989, ranked first in the University of Bombay in the DM cardiology examinations held in October 91. He has a wide range of experience, invited as faculty for Malaysian Life Conference in 2007, as international faculty for TCT San Francisco, USA 2011, international faculty for Euro PCR, organizing secretary for India Live 2011, Mumbai, India. He's been invited as faculty for India Live 2012, 13, 14, and 15, member of Indian College of Cardiology, ICC, member of Cardiological Society of India, CSI, member of European Society of Cardiology, ESC, awarded fellowship in the Society for Cardiovascular Angiography and Interventions, FSCAI. To do the honors for felicitating him, may I please invite on stage Dr. Gajendra Yadav. May I please have you on stage, sir.